People don't choose to have a mental illness. That to me is really important. There's an individual there that is seeking help, and they just don't know how to express it in a way that actually comprehends to other people around them. People often think it's just a matter of choice, and sometimes people don't have the ability to rationalize a choice.
Welcome to Content Matters, where we go behind the scenes of content in high-stakes environments. Today I'm with Bill Campos, who is on the board of the Mental Health Coordinating Council in New South Wales. He has 25 years experience as a psychologist and an advisor. We're going to unpack one defining case, what it revealed, and how to communicate hidden costs to facilitate change. We're going to be discussing Australia's mental health system and where it can heal or harm depending on design. So Bill, welcome. Thank you very much for being my guest today.
I'm glad to be here. And yes, it is a very important topic.
Tell me, Bill, what did early mentors teach you about separating incidents from personal attacks?
Throughout my early days as a career psychologist, there was important lessons that I've learned, particularly from the people that were supervising me or the mentors, of understanding how to separate the care process from what could be interpreted as a personal attack. You do need thick skin to work in some areas of mental health where you need to show enormous empathy for people that potentially are showing behaviors that are quite confronting, but having the understanding that these behaviors are essentially expressing the pain that they're experiencing.
Thank you. I asked a question about what you learned early on because I think it's really important context to how you approach your work today. You've told me that you learned early on to work yourself out of a job, right? Because your goal is to help people feel like they're able to care for themselves or support themselves through the community of those who can help them as well. Do you remember a point when that clicked in practice for you?
Yeah, there were a few scenarios where that kind of lesson hit home. One of the things is that when you help someone through a journey of care as a psychologist, assisting people to get through a particular part of their situation, you can get to the point where that process is already what we call healing. Your job as a psychologist or a mental health professional is to get persons to the point where they can start having that insight for themselves. Part of psychology or mental health is that there is a transference account where people can rely on seeing a psychologist for their issues or problems, but not necessarily owning them. They see themselves as having to manage the problem, but not necessarily being able to have the tools to resolve them for themselves. So a great mentor said to me is that you have to keep in mind that you're not here to create a long-term relationship with a client. You're creating space for them to be safe, to express things that are very dark in their own psyche or in their own lives, to be able to understand and peel away some of the complexities that they find lost in. Hopefully you've created a space where they can start having those insights for themselves. You need to create the space where you remove yourself from that therapeutic process. And that is a really important lesson. I think one that sometimes we forget as psychologists that we're, helping professional. A key part of any helping professional is that you work yourself out of a job. You create space, you assist someone through a particular point in time. You understand a little bit about what the complexities of their situation is, and you are hopefully trying to unravel some of that so that they are in a better place for themselves and people around them can actually find a meaningful direction. And I think media sometimes portrays that everyone has their own therapist or psychologist. Some areas of this sector still see therapeutic issues as a long-term journey. But the key point of any care profession is that you work to the point where someone feels well again and heals so that you no longer have to continue to support that person through a process.
When did you first notice that the system rather than the client was the blocker?
There's been a couple of very big examples where you start to understand that how we provide care can sometimes not be the best pathway for individuals. Generally, I can talk a little bit about the structure of how obviously a mental health care system is that you're feeling unwell, you go and pay for a service that hopefully alleviates that pain for you. And if you look at it purely from a financial perspective, as a psychologist, you support people when they're unwell. The system is designed where if people are unwell and remain unwell, they continue to seek help and services. If you look at it from a helicopter point of view, you find that as people become more unwell, the more and more need for them to see a psychologist to continue therapy and services. I think sometimes we need to look at it and understand whether the financial and system design is actually helping people stay well, or if they become unwell, to become well, and where the incentive is for a helping professional to stay well. Now, that's a general example, but I think also there are scenarios where you start to understand acute cases where people need hospitalisation. You start to see the blunt instrument that some hospital systems provide in terms of supporting people with mental health needs. With hospitals, when people are really unwell and they come to hospital via an ambulance or police, they are very unwell. Usually the system doesn't have the time to understand a personal situation when they're extremely unwell. So often somewhat geared towards just reducing the impact of the symptoms. If someone's delusional, aggressive, or psychotic in some ways where they're irrational, the system is designed to contain that in a way that keeps them safe and risk management. Once that risk is mitigated, the process is for them to return to the community. What I find is there are some clear gaps in transition of care when people go from home to the hospital, from the hospital to the community and back home again. There are quite a lot of inequalities and accessibility issues around how they have that transition of care or journey of care that makes it better aligned to the individual's needs. The administration and referral system comes in, open door, all those things plays out in a way that potentially is not necessarily the best course of action for someone who might be unwell.
If I was to ask you to summarize what's broken about the current health system, how would you explain it to someone in just a couple of sentences?
I don't like the term saying the system is broken. I think the system is developing. It's always developing and is trying to get better. And yes, there's a huge number of flaws, and obviously we hear a lot from media about how the system is broken. To be honest, the system is always evolving and always trying to be better. I've been in the sector now for 25 years, and there are things that you can see over time that are getting better. Having said that, though, there are still enormous gaps, and part of it is on two fronts. One is the scientific practice of understanding mental health, because there's still differences in understanding what mental health is. Probably two reasons. One is there's no physical or biological test that we can go and find out whether or not someone has a mental illness. For example, if you have diabetes or cancer, you can do a biopsy, you can do some tests, and you can find some clear markers to understand what the person might have, which is quite a significant step towards identifying what type of illness someone's expecting. With mental illness, it's a little bit different. We haven't articulated well the intricate different ways of actually identifying the intensity, but also the severity of these mental health presentations. For example, mental health can be suicide, could be eating disorder, could be a schizophrenia, could be manic depressive, could be anxiety, could be stress, neurodiverse. Mental health has a huge scope, and the system is essentially geared towards reducing the symptoms associated with severe cases.
If I'm interpreting you correctly, one of the biggest challenges is that when people present with mental health challenges, the immediate priority is to de-escalate or provide an environment of safety. It's not necessarily an overnight success to fix somebody straight away.
Spot on. I think that's probably my experience. It could be summarized in the way you just described. The system is just trying to mitigate risk in terms of how someone goes through the symptoms. You could say there's two parts of this. There's a treatment part where you treat the symptoms, and there's a care pathway, which is to do with how people find the insights to become better and learn from the lessons they had. People sometimes get affected very differently for different reasons. There are people who are extremely paralyzed by grief, for example, and that can significantly affect their mental health. Other people may go through grief and not be affected as much. And so there's a huge spectrum of understanding people's internal resources to try and manage mental health and resilience.
Let's zoom in on a particular story.
Yes.
Would you mind sharing a defining moment in which you saw the ripple effects of a system that demonstrates this challenge?
A particular incident of a person I know who was in his early 20s, experimented with some drugs and became quite unwell, delusional and psychotic. And that person eventually was admitted to hospital because he was quite unwell under duress, because obviously this person didn't want to go. So there was an element that they needed to go through and be pulled by ambulance to take him to hospitals. In fairness, also, the ambulance staff were great. Because a person's quite delusional and unaware of their behaviours, he can be interpreted as quite aggressive and quite irrational. So there is a huge skill set that I think first responders have in terms of understanding that. Where my experience showed significant flaws in the system, when this person was admitted to hospital, he was in a public hospital. When I went and visited this person in the hospital, I was taken aback by the way it was designed. So it was an open area where potentially there was 20 or 30 people who were also unwell. They were put in, and staff were behind this kind of glass area where they had nurses. And there was very little interaction. Every time someone wanted to help, they had to knock on the glass and ask for help. It was almost like a jail process where people were in the space where they can go outside. It was a locked dorm area. This particular young gentleman had to share a room with someone who's quite unwell, and someone who was much older than them. They was about in the 50s years old age. It was run in a way that they had morning breakfast, lunch and dinner, and a few psychologists and psychiatrists occasionally visiting and touching base with every one of these clients that were in the hospital at that time. The bit that really stuck with me was after about 2 weeks, this particular gentleman was starting to be quite well. In my experience, I know this person reasonably well, appeared to be getting well again, and he obviously wanted to be discharged quite quickly. It just so happens that I think it was a Thursday or a Friday, wasn't able to be discharged until it was signed off by a psychiatrist. The psychiatrist, I don't think, was going to come back until Monday or Tuesday the following week. So even though in my mind I saw that this person was quite reasonably well and was able to now go back home, or at least having some community supports, the administration was that he had to be signed off and discharged through a psychiatrist. Because of the staffing and the lack of resources in this hospital, we had to wait until the following week, which is the Monday. Over that weekend, because you are in a hospital setting with a number of people coming in and out and quite unwell, this person had to share a room. He was assaulted by this other person that was sharing, which then became quite unwell shortly after that incident. He was locked up in a hospital ward with people he didn't know. A lot of people who are quite unwell, it's quite distressing to be around them after that event and that weekend. The psychiatrist came back on Monday and he saw that the person was unwell again, meant that they prolonged his stay at the hospital for another 2 weeks or so. That to me was a flaw in the system, because the last thing you want is when someone's well, the hospital system should actually make every avenue available for the person to stay well. With the environment they were in, I felt that was one of the incidents that potentially made this person unwell. For whatever reason, design, administrative resources, we can talk about all the problems we have in the system. A lot of it's to do with resources and administrative design. To me, it highlighted that if someone had cancer or diabetes and they were well, they'll be going home.
How did that patient feel when somebody told him he had to stay longer against his wishes?
Yeah, he was heartbroken. It's a very difficult process because he escalates and gets more anxious. He obviously doesn't want to be there. He misses his family. The thing that really struck me, because he stayed for so long, he actually stayed, I think, overall 5 or 6 weeks. His job was at risk. He was a young apprentice. Potentially, when he came out, he lost his job. There was issues, obviously, with his family and his girlfriend. How do you actually explain to someone that you've been in a mental hospital for 5 or 6 weeks over that time and not having any kind of transitional support? Essentially, when they get discharged, there's quite a quick assessment done by the mental health staff at the hospital. But I don't think it takes into account the success factors of what could happen when they're going back to a place where the relationship with the girlfriend has been severed, the lack of knowledge or preparation that the family has in terms of them returning home after having such an episode. There's a whole treatment guide too. They're left with enormous numbers of medication, a lot of referrals to go and see. The onus is obviously going back to the individual, the family, and possibly a GP. But there's sometimes very little alignment of care back into the community. So this young person, in my mind, severely was affected by the hospital treatment because he did impacted on his ability to return to employment, impacted on his ability to have a relationship ongoing with his girlfriend. And there was a lot of questions and answers as well from the parents. For them, how do you actually make sense of someone going to hospital for that long, mentally unwell, and then what's implications for them when they get home? How do they continue care and relate to this person? Because it is a shock to the system when someone is in a mental health. Again, the system is not unbroken. The system needs to evolve because it depends on which hospital you go. You get much better treatment and care because of the design and resources available to them. So if this person went to another hospital in another area, much more affluent, you probably find that wouldn't be sharing a room, and you probably find that there might have been a psychiatrist there every day of the week. Whereas this particular case in this hospital, there was a huge demand and there was a lack of resources and gaps in staffing.
It's the problem because without the resources, the patient can't get back into their community where they have
Mm.
supports, which are often overlooked as part of the healing process. And then what you're saying is he basically lost his job, his employment prospects, and that's a huge anchor for someone's well-being.
Yeah, exactly. Exactly.
I think it's quite challenging for many reasons, but
Mm.
your role is the psychologist. You don't run the hospital, you don't create the rules. What could you have done in your power, or in hindsight, what would you have done differently to change the trajectory of that patient?
If I had my time again, two things off the top of my head that would have been one is that if a person starts to show symptoms that they're actually quite well and coherent and have the means, as soon as some of those things are consistent for 24 hours, they should be discharged. And that discharge should be associated with a community engagement liaison officer that goes back into the home or the GP and has some sort of continuity of care outline in terms of what happens after that. I know this is a costly exercise. It's very hard to have these case managers to go into the community, but I think this is where we'll talk a little bit later on about some of the digital implications where it can assist some of these things. The second thing I'd say is that when someone's really unwell, particularly when they're mentally unwell, they shouldn't share a room. That to me is a lack of foresight or design by the administrators at the hospital. If I had a magic wand, I'd go back to the administrators and say, this is a new policy. You can't have a room that's shared, particularly when people are unwell and they're all different age groups and strangers that you're going to be sharing a room with. That's not good practice.
So, seeing everything that you've seen and what you know now,
Mm.
you've talked a lot about this transition in care. I would love to speak to you a bit more about that. Can you talk to me what the biggest opportunities are and what does a good transition from hospital back into the community look like?
Someone in the community already knows the patient quite well, or it may even be the parents or the carers. I believe in my mind there are a few things, but one of the things is the liaison with the family. Usually in the past, you'd had some social workers or community services, support workers that would take on that role. Now, with a lot of dynamics and resourcing and funding is an issue, those things are a bit of a luxury and not available to all hospitals. That would be a great step in the right direction to have some social workers that potentially discharged from the hospital, engaging with a psychologist in the community, having some liaison with the family. The big things that's happening at the moment is what they call the lived experience peer workforce. These are people that have gone through experiences of transitioning from hospitals and have insights as to what was helpful for them when they actually discharged that they can give insights to. So I'm a big believer in the lived experience peer workforce that could create a lot of insights and that personal narrative as to what helps people to transition back home. Things like talking to an employer or sending a letter out to an employer to say that you're ill, having your rights of understanding what your privacy is, that you don't need to tell your employer or other people about your condition, understanding how you need to maintain your medication and why is it important to understand what works for you, even though medications are given to people, they not necessarily take it all the time when they're not very adherent to that sort of stuff. And with a lived experience peer workforce, they have some of these insights that actually can provide quite good information to those people who are transitioning out of hospital. I also know that with the digital space now, I think is something that can actually continue that care, and you can have touch points that allows people to have visibility.
With a successful transition into the community, sometimes resources are limited, as you said. This is where I think digital self-help tools can play a really big role. Do you want to explain what you're seeing in relation to what education is and resources are available to people?
There's a huge number of resources available to people now. There's a lot of forums, there's chat rooms, there's helplines, there's an array of services out there. I think most people are aware of that too. And the technology is moving at such a quick pace now. So obviously we're talking about AI now, where it can be precursors, you can interact with things. So there is the opportunity here. If we're designing a system, you would design it quite seamlessly between a physical and an online environment where essentially the patient or the client, person who needs help, is able to not only advocate for themselves, but also navigate the systems that they think is important for them. The system is evolving towards a better place, but it's still a long way to go.
That's an excellent overview. Based on what you're seeing, is there anything that digital self-help tools and education are not good for?
Too much of anything is a bad thing. Technology has been so inundated with information that it's hard to identify the authenticity and the good information. I think that's what's, I suppose, in some ways detrimental in over-relying on digital resources. There's not a way of sifting through what is credible, authentic, and real information as opposed to other information out there. The internet is designed to grab your attention, not necessarily to make you well. There are some tricky navigation processes. People need to get good help online. It is important to refine your search and trust people who you interact with to guide you some of these tools that actually help.
If you spend a lot of time and an effort advocating for positive change in mental health, I'd love to ask, when you talk to policymakers, are there specific words that you use to help land your message?
Part of advocacy is also making it relevant to the policymakers and to the government. Often you use terminology that grabs their attention. Advocacy is usually around something that can reduce cost. When you're advocating and you're looking for funding, the best way of getting some attention is whether you can showcase a service or a program or a professional intervention that shows good outcomes, but also cost effectiveness. So when you're advocating for new services, they're the two things I think how effective it is and how efficient services can be on a larger scale. And that usually gets the attention of government officials because that's ultimately what they want to do, is to support more people with great outcomes with the least amount of tax dollars as possible.
Yeah, talking to policymakers is I've got an idea for an initiative, it's the potential investment, but if you don't invest in this, this is the trade-off. Or if you do, here are the benefits. Some of those things could be the cost to people's well-being if they lose their jobs, the cost to families and relationship breakdowns because people can't get better sooner. The upside is that when people are better, they're more productive and contribute to a healthier economy. Lee, would you say these are the kinds of things you're saying?
You've nailed it.
What else
Exactly
is
right.
there?
There are some measures that I think the government uses a lot in terms of just quantitative. So, for example, bed days, how long they were in hospital for, hospital readmission rates, what are the costs per night or per overnight, 24 hours. Those things are some of the measures that I think governments use just to manage the baseline of hospital administration. Bed days, hospital readmissions, interactions with frontline staff, whether it's police or ambulance, there's other ones as well. And then you have other parameters as well, like whether the person is able to hold down a job, whether they're able to have other physical health needs as well. If someone's really mentally unwell, they're less likely, or at least potentially have other health issues associated with that as well.
If you could leave listeners with one key thing you want them to remember from this conversation, what would that one thing be?
I think the important part is that people don't choose to have a mental illness, whatever kind of illness they have. They are looking for something that will make them well. That to me is really important. There's an individual there that is seeking help and they just don't know how to express it in a way that actually it comprehends to other people around them. People often think it's just a matter of choice, and sometimes people don't have the ability to rationalize a choice. The other part of the message is that I would encourage people to think about that the system's not broken, it's evolving. I spoke in another podcast, with diabetes, you have type A and type 1 and type 2 diabetes. One's associated with a lifestyle and the other one's associated with a genetic disorder. I think mental illness could be looked at in the same sort of vein, where there are people who have some mental health concerns because of the lifestyle, situation, environment impacts on them. It might be grief, traumatic events, certain things. There are also people who genetically have a predisposition for volatility about their mental wellness, which they've struggled to maintain. As we discover and understand mental health and mental illness or mental wellness, I think we need to articulate the differences in those presentations and become more aware of those differences.
That's incredible. So,
Mm,
Bill,
mm,
the type of future you see, the utopia, if we talk about the utopia you see for mental health, it's that there's no stigma. It's that people have a better understanding of where some of the mental health challenges might be coming from, whether it's lifestyle or whether
mm.
it's genetic. Would that be a fair assessment, or do you have another way to articulate your vision?
I'm a big believer in prevention and recovery as opposed to treatment. So I do believe that there is an avenue for people to express their mental health in a way that promotes better mental health. I think the utopian view of this is that people have safe spaces to express their individuality in a way that maybe are able to do it in a safe way as opposed to be in a way that could harm others or themselves, which is where the difficulty lies with some of the mental health concerns. I think that's a bit we need to do more work on.
Thank you so much. It's been a real pleasure getting to know your expertise. Now, if people want to find out more, where should they find you?
I work for an organisation called ICLA, which is Independent Community Living Australia. We have a website, icla.org.au, and we deliver a lot of services across the spectrum, whether it's with disability, homelessness, aged care, and community mental health. You can find out some of the work we do in pioneering some of the services associated with mental health. And if people want to drop me a line, they can through the website, the receptionist, email, or telephone.
Thank you, Bill.
You're welcome.